happy to have a customer, Dr. Gordana Raka. She's the director of the Cytogenomics Laboratory at the Center for Personalized Medicine at Children's Hospital, LA. And she will be giving a presentation on her analysis and how NX Clinical has helped her with that. I'm going to hand it over to Dr. Raka and we will begin. Dr. Raka?
Thank you very much. So hello, everybody. I would first like to thank BioDiscovery for the opportunity to present today. And I want to thank everybody in the audience for taking the time to join us today. So as you see from the title, I will be talking about how integrated review of sequence variants, copy number variants, and treatments of homozygosity, which is enabled through NX Clinical, can help us in more accurate diagnosis of both Mendelian disorders and pediatric cancers. So my talk will be divided into two parts, and in the first part, I will be talking about constitutional diseases, and then in the second part, I will be focusing on cancer. So starting with constitutional disorders, we know that genetic diseases are caused by different mutation types, including sequence variants, copy number variants, and even completely balanced structural rearrangements. So if we take congenital anomalies as an example, in approximately 25% of the cases, they're caused by growth chromosome rearrangements, which are visible by karyotyping. About 10% are caused by submicroscopic deletions and duplications, and approximately 20% by single gene mutations. So if you're a clinical laboratory, you have to be prepared to do testing for all these different mutation types. For example, it has been shown in this publication from last year that if you're testing for monogenic disorders using NGS panels, that a significant proportion, in this case about 10% of all the pathogenic variants that were reported from NGS panels, in this case in Invitae, were actually not sequence mutations but copy number variants, deletions, and duplications that were either partially or completely deleting individual genes. And so again, stressing the importance of performing testing both for copy number variants and sequence variants when you're doing testing for genetic diseases. So here at Center for Personalized Medicine, we offer genetic testing using both sequencing and tests for copy number abnormalities, but we, for the most part, do this as two separate sets of assays. So for sequencing, we perform testing using everything from clinical exome sequencing to single gene sequencing. And for data review and analysis, we use a variety of tools from custom pipelines to different commercial softwares and packages. And then we do copy number testing using, for the most part, array-based platforms, different types of arrays. And again, that comes with its own sets of tools for data analysis and data review. So by using these different tools and doing this testing separately, and not only we have some loss in efficiency and increase in cost, and being since it's necessary to purchase licenses for multiple different software tools. But what I also want to illustrate with today's talk is that by doing this disparate separate review of copy number variants and sequence variants, you may actually miss or misinterpret some important findings in your patient. So to illustrate the second point, I would like to start with some cases that are coming from our ocular disease-focused exome. This is a test that we offer at CPM to make a diagnosis of genetic eye diseases. It's offered on whole exome backbone, but analysis includes 259 genes that are implicated in genetic eye disorders. And most importantly, this assay is used to detect patients with retinal dystrophies, because there is a gene therapy trial for these patients that's open at our CHLA Vision Center. So this assay is used to detect patients who are eligible for this gene therapy trial. So the first case that I wanted to show was a patient, an 11-year-old girl with a diagnosis of Leber congenital amaurosis, in whom sequencing using this focused exome for ocular diseases detected a pathogenic variant in the gene NMNAT1, which is a known gene for this disorder, for Leber congenital amaurosis. And this variant that was detected was a known pathogenic variant reported previously in many patients with this disease. The only issue was that this is a recessive disorder. So one mutation does not explain the phenotype, is not sufficient to cause the disease. So we knew in this case that we should be looking for possibly copy number abnormality or some motor mutation type in the second allele. So we did analysis of NGS data for copy number variants using our custom tool. And there was indeed a deletion call in the gene in the patient sample. One can even appreciate that there is decreased coverage for some of the exons compared to other samples in the same batch. And this deletion was then confirmed by our exon level array, showing two exon deletion in NMNAT1. So now we have two mutations, one deletion, one known pathogenic sequence variant, and this now establishes the diagnosis of this recessive disorder. However, doing this sequentially in two phases using two different sets of tools and pipelines for copy number analysis and for sequencing analysis caused some delay in establishing this diagnosis and getting to the answer. So if you look at the same case in NX Clinical, you very easily and very quickly see two events in the same gene, two exon deletion, and then a pathogenic sequence variant. And there's also a filter that you can use in NX Clinical that will highlight for you genes where there are multiple events and sequence and copy number variants in the same gene. And so this will really streamline detecting these types of events in recessive genes, for example. And more importantly, in this particular case, we did not miss the diagnosis because the first variant that we detected was the known pathogenic variant. So we knew that we needed to pursue this further and look for copy number abnormality in the second allele. But if the first variant was a VUS in a recessive gene, even with very strong VUSs, it's not part of our routine process to follow up on VUSs in recessive diseases by looking for copy number variants in the second allele. Although there is a possibility when you have a strong VUS, if you find another clearly pathogenic variant like a partial gene deletion, you can upgrade that VUS, use that as additional piece of evidence, and maybe make a diagnosis of a recessive condition. So you can clearly see that by not highlighting these multiple events in the same gene, there is some potential to miss a subset of diagnoses for patients with recessive disorders. Another quick case, again coming from our ocular-focused exome, was a patient with bilateral cone dystrophy. And here sequencing detected what looked like a homozygous mutation. It was a clear pathogenic variant because it was disrupting a canonical donor splice site, and it was in the POC1B gene, which is associated with this particular phenotype. So one would be tempted to finish the analysis at this point. This is a recessive disorder. There seems to be a homozygous pathogenic variant. However, our director who was reviewing the case was cautious because this is a very rare disorder, and probability that unrelated parents, and there was no consanguinity mentioned in the family, that unrelated parents will be carriers for the same mutation is not very high in the general population. So just to make sure, we'll look whether there is a copy number variant in the second allele, and sure enough, there was an overlapping deletion that was called by our copy number tool from NGS that detects copy number abnormalities from NGS data. And again, we went ahead to confirm this by exon level array. And so in this case, again, looking at the same case in NX Clinical very quickly shows you that there is a deletion that overlaps your sequence variant, and that's why the sequence variant appears as a homozygous mutation when you do just sequence variant review. And the filter that I mentioned earlier that will show you genes where you have multiple events in the same gene is highlighting this particular gene as one that has both copy number loss and sequence variant. And again, just highlighting how clearly you can see two events using NX Clinical. So just to illustrate that these events are not rare in isolated examples, I wanted to show this paper that illustrated that copy number abnormalities are actually very common, specifically in genes for retinal dystrophy and other genetic eye diseases. And there are other disease types where the same thing has been established. genes. You often have copy number abnormalities that disrupt those genes, neuropathies, neuromuscular disorders, and many others. And so in all these disease types, it's very important to be testing for both sequence variants and copy number variants, and a tool that allows you to do that quickly, efficiently, and not miss those events is very useful. But the case that for us, the most clearly illustrated the utility of being able to see simultaneously sequence variants and other types of variants was this case that was actually analyzed by my colleague, Dr. Jenny G. And she presented this case previously at the ASAG meeting last year, but I still decided to go over it today because as I mentioned, it really communicates this point how useful it is to get a full picture and be able to see sequence variants and other variant types. So this was a male patient who presented with active myeloid leukemia with myelodysplastic features, which is very unusual to see in very young patients. And they do get AML, but it's very rare to see AML with myelodysplasia. And the patient has some other phenotypes, developmental delay, short stature, and some previous genetic workup was done. Array was done in Noonan panel, but all the findings were negative. So this is just showing very complex karyotype of the leukemia clone. As I said, very rare to see this in young patients. And we also did array analysis on the bone marrow sample, on a leukemia sample that shows the same complexity that was expected based on karyotype, a lot of copy number gains and losses. And I want to point that there was copy neutral LOH in 17p, which made us think that there could be a TP53 mutation, which you see in AML with myelodysplastic changes, and it's associated with poor prognosis. So seeing this copy neutral LOH was concerning for having a very poor prognosis and AML in the patient. So the patient was treated for leukemia, and he was in remission. But clinicians also wanted to pursue his genetic diagnosis. It was felt that he might have some cancer predisposition because it is unusual to see AML with myelodysplastic changes in pediatric patients. And also there were those additional genotypes that were not, phenotypes that were not explained in this patient. So they ordered trio exome analysis on the remission peripheral blood sample, thinking that the patient is in full remission, and you can use this sample for germline testing. And trio exome showed what looked like a de novo heterozygous mutation in the TP53 gene. And so we see that it's absent in both parents and present in the patient with about 57% variant allele fraction. So it really looked like it could be a germline heterozygous mutation. And this was a well-known mutation, pathogenic variant in TP53, seen in multiple families with Lister-Maney syndrome, and it also looked like it was de novo in the patient. And it also looked like it could explain his AML phenotype, his cancer phenotype, although it could not explain those other features that were present in the patient. So it was classified as a pathogenic variant, probably constitutional. But we did mention at that time that there is a possibility that we cannot exclude, and that there could be residual MDS clone in the sample, and that there was a possibility that this could be a somatic variant. However, we didn't really have high level of suspicion that that would be the case, because it was the variant was present in about 50% of the reads, and it seemed to explain the patient's patient's cancer phenotype. And so it was interpreted as more likely germline. However, as I mentioned, it did not fully explain the clinical picture, and there were all these additional phenotypes. So it was decided 18 months later to do reanalysis of exome data. And at that point, we also looked at the case in NX Clinical. So this is now copy number analysis from exome sequencing data from NX Clinical. And to our surprise, we see clearly copy neutral LOH in 17p in this peripheral blood sample, which, if you remember, was also seen in bone marrow at the time of acute myeloid leukemia diagnosis. So this was a somatic, almost certainly a somatic change. And this indicated to us that in this peripheral sample, there was actually residual MDS cells, an MDS clone. And so if at the time of initial exome diagnosis, so we did the second view, we had the second view and ability to see not just sequence, but copy number variants and LOH, we would have interpreted the TP53 mutation completely differently. We would have been alerted to the fact that there are probably residual MDS cells in the sample. So in addition to then suggesting that a P53 mutation is somatic, what was also found in reanalysis was a pathogenic mutation in another gene, DNA GC21. Here you see homozygous mutation in the patient, and then both parents had heterozygous carriers. This was clearly pathogenic variant with a stop codon. In the gene that codes a protein that's involved in a ribosomal subunit maturation. But importantly, this gene was, after the initial exome analysis was completed, in subsequent years, described in association with a disease that manifests with bone marrow failure, susceptibility to leukemia, and some of the additional features that were seen in this patient. In other words, this gene mutation in this gene is a very good explanation for all the phenotypes present in this patient. But at the time of initial exome analysis, the gene was not known as a disease-causing gene, and we were not able to establish the diagnosis at that time. So here is just a summary, showing what are the phenotypes associated with pathogenic variants in DNA GC21, and highlighted are all the features which were also present in our patient, and just demonstrating how well this fits the patient's phenotype and explains all the aspects of the patient's presentation. And then in terms of TP53 variant, we were able to reinterpret it as most likely being somatic variant in the residual MDS clone. And additional indirect evidence that the TP53 variant was most likely somatic is if you do calculation of variants based on variant allele frequency. So I mentioned that TP53 was present with variant allele frequency of 57%. So if you estimate what is the proportion of abnormal cells in the sample based on B allele frequency, and a clinical also allows you to do that automatically. And so estimated proportion of abnormal cells that have LOH is about 56%. So if you assume that these cells have biallelic TP53 mutation, then that would give you that 57% variant allele frequency that we saw by our sequencing. However, if you assume that this TP53 mutation was germline, then in the clone that has LOH, you would see it in all the reads, so that would give you a 56%, and then all normal cells would have it as heterozygous, which will give you additional 22%. And so the total variant allele fraction would be 78%, would be estimated to be around 78%, so much higher than what we actually saw it at 57%. And so even by looking at variant allele fraction, it's very suggestive that this is not a germline variant, that this is actually acquired somatic variant in the residual MDS clone that was present in the peripheral blood sample without us being aware of it. And so in conclusion for this case, with exome reanalysis, positive DNA GC21 variant was detected, which fully explained the patient's phenotype. And then TP53 mutation could be reinterpreted as somatic. And this was all enabled, of course, by new knowledge about additional genes implicated in human genetic diseases. So that illustrates how important it is to periodically reanalyze exome data. But also this more accurate interpretation of the findings was enabled by being able to, by seeing concordantly sequence variants and other types of variants, in this case, copy neutral loss of heterozygosity in 17p. If we saw that during initial analysis, we would have completely differently interpreted the TP53 variant in this sample. So to summarize this part of a talk that focuses on constitutional disorders, what we see currently as a typical workflow when a genetic disease is suspected and there is no a very specific disorder that is in a differential, and that chromosomal microarray, and if that is negative, and then typically exome sequencing is ordered, or focused exome if the phenotype is more specific. And then if exome is negative, or you see only one mutation in recessive gene, and then we are continuing with copy number variant calling from NGS data. Then if we find candidate copy number abnormalities, we confirm them by exon array. But doing this algorithmically and in succession, it obviously takes much longer to get to the final diagnosis, and it also it results in additional workload and increased cost to get to the diagnosis. And so where the field seems to be moving is more and more towards integrated copy number analysis and sequence variant analysis from NGS data. So whether you're doing sequencing of the whole genome or exome, focused exome, NGS panels for specific disorders, and more people are doing integrated detection of sequence variants and copy number variants, and even regions of homozygosity, and then you can do a complete workup for different types of variants in the same process and in the same workflow. And in that respect, NX Clinical is ahead of the curve because it is an application that already very well supports both sequence variant analysis and also copy number variant detection and analysis from NGS data. And so now I would like to switch gears and show how integrated data review and analysis is also very important in tumor testing. And so when it comes to genetic abnormalities that are associated with cancer, there is even more complexity there than in constitutional diseases. Oncogenic drivers can be sequence mutations, can be abnormal gene fusions, deletions, duplications, amplifications, copy neutral LOH. And so to perform clinical testing for cancer cases, labs have to be prepared to detect all these disparate types of variants in tumor samples. It is also very common to have two hits in the same gene. In tumor suppressor genes, you have the second hit that results in a loss of wild-type allele and complete inactivation of that tumor suppressor. And then in oncogenes, you often have duplication of the mutant allele as a part of tumor evolution. And then these two hits are also typical for cases of hereditary cancer predisposition, and where the first hit happens is a germline change, and the second is somatic change in the tumor sample. But often when you have these two hits, they represent different types of mutations. So the first one could be sequence mutation, and the second would be deletion or copy neutral LOH. Or the first would be deletion and then copy neutral LOH. And so to accurately detect these events, you have to be able to detect different mutation types in the same sample. So knowing all of this and how important different types of mutations are in tumors, when we do cancer testing at CPM, we make sure that every tumor sample gets tested for both copy number abnormalities and for sequence variants and for fusions. So the way we do that is that for copy number abnormalities, we do whole genome arrays using different platforms depending on the sample type. And then we also have our custom NGS panel for sequence variants and for abnormal gene fusions. So this panel was custom designed to have content that is adjusted to pediatric cancers. We developed this in collaboration with Thermo Fisher. And so we call it OncoKits, but it's also offered through Thermo Fisher as pediatric Oncomine. And DNA portion of the assay tests for sequence variants in large number of genes that are associated with pediatric tumors. And then there is also RNA part that tests for a large number of fusions, abnormal gene fusions that are associated with pediatric cancers. So right now, our workflow is such that we separately do CMA analysis for copy number changes and then OncoKits analysis. And then these results are reviewed and analyzed separately. And then at the end, we try to correlate the findings. However, we were wondering whether we could review these results of these two tests combined in NX Clinical, whether that will be helpful with our efficiency and also accuracy in interpreting the findings. and especially whether it would help us to highlight those two events that may be affecting the same gene. And so to start answering these questions, I wanted to first show a very easy case. So this was a case of T lymphoblastic leukemia, whereby oncocytes we see sequence variant. It's a truncating variant, introduces stop codon. And CDKN2A is a known tumor suppressor gene, so you would expect loss of function variants. And then we also see very high variant allele frequency, 90%. So you anticipate that there is probably a second event that results in complete loss of CDKN2A. And certainly by array analysis, now we see copy neutral LOH in 9P, where CDKN2A is located. And all this is not surprising, because in TLL, abnormalities of 9P and specifically biallelic abnormalities in CDKN2A that result in complete loss of the function of this gene are seen in 70% of the cases. So we see a lot of cases with abnormalities of this particular gene. However, if you look at the case in NX clinical, and even if you do not see a lot of TLL cases and don't have experience with this particular tumor type, you can very quickly appreciate that there is this region on chromosome 9 where there's two abnormalities in the same region, sequence variant, which is indicated by the symbol, and then allelic imbalance. And if you zoom into that region, you can clearly see, again, sequence variant that occurs within the copy neutral LOH region. So as I said, in TLL, that case was not particularly difficult for us because it's a common abnormality and because we had high variant allele fraction to point out that there are probably two events and that there was probably a second event affecting the same gene. But that correlation is not always obvious, and it's not always so easy to make. So I want to now quickly show another case. This was BALL. By karyotype, we detected derivative chromosome 19 from translocation 119, which is a known abnormality in BALL, which results in CCF3-PBX1 fusion. And then by array, we saw gain of 1Q and loss of 19P, which was consistent with that derivative chromosome 19. However, we also see copy neutral LOH in 3P in the short arm of chromosome 3 in the region that's not typically associated with BALL. So initially, this had to be interpreted as having unknown significance for BALL pathogenesis. However, then we did oncocyte sequence analysis as a separate assay, and there is mutation in SETD2 gene that was detected. It was a clear pathogenic variant. It was in canonical splice site. And SETD2 is epigenetic regulator, which is known to be mutated in about 4% of BALL. And so it is an important gene for BALL pathogenesis, but it's mutated a little more frequently. However, it's clinically important because there are some indications that epigenetic mutations are associated with increased resistance to chemotherapy. And however, as I said, this is not a gene that where we see mutations often. So in this particular case, it actually would have been very easy to miss that the gene maps on 3P within that region where we saw copy neutral LOH. However, if you review the data as combined in NX clinical, where you can look at sequence variants and copy neutral LOH together, and then this region where you have two events in the same region is becoming very obvious. And now when you zoom into this region, you see sequence variants that happens within in the copy neutral LOH region. So now copy neutral LOH could be interpreted as most likely being related to the presence of this pathogenic mutation. And this is a second event that is probably leading to development of a subclone where you have complete loss of SETD2 function. I also mentioned that sometimes having two hits in the same gene serves to us as an indication that we should be thinking about possibility of germline predisposition, because germline predisposition mutations are much more common in cancer patients than it was originally appreciated. And this was realized when sequencing sequencing tumor samples for somatic mutations became much more prevalent. And then it was realized that through that process, you more frequently frequently than expected, you also detect predisposing germline variants. So there were multiple studies in recent years that specifically looked how frequently, when you do somatic panel testing in tumor samples, how frequently you will detect germline predisposing variants. And this was done in both pediatric cancer patients and in adult cancer patients. So the first two studies on the top are focusing on pediatric patients, and you can see that in at least 10% of these patients, there is germline variant, germline predisposing variant, that is probably underlying the development of the cancer that these patients were tested for. However, most of these patients did not have previous family history and were not suspected of having germline predisposition. So we're very, and I also want to mention that this 10% is probably an underestimate, that these studies were designed in such a way that they were not able to pick up all possible germline variants. There are some estimates that the actual number is more 15 to 20%. So we're very aware of this possibility of germline predisposition when doing testing for our cancer patients. And we actually looked at our own data. And so when summarizing our OncoCase results, we looked at how often we detect variants of diagnostic significance, prognostic significance, therapeutic significance, and then we also looked how often we detect variants that may be germline and may be predisposing germline variants where we have to recommend follow-up germline testing. And it turns out that in more than 20% of our solid tumor patients and CNS brain tumor cases, we find a variant that is suspected to be germline where follow-up germline testing is justified. So in some cases, this possibility of germline mutation is easy to recognize because there is a very well described association between the tumor type and germline mutation in a particular gene. So, for example, if you take osteosarcoma, it's known that almost all cases of osteosarcoma have TP53 mutations, often just as somatic mutations, but then a subset of these patients also have germline TP53 mutations associated with Leber syndrome. So when we see patients with osteosarcoma, we are on high alert, and we will typically recommend germline mutation testing. So just a quick illustration: this was a patient with recurrent osteosarcoma. CMA analysis showed complex abnormalities that are characteristic for this tumor, including deletion in 17p, overlapping TP53 locus. Sequence analysis through OncoCase detected TP53 variant that was previously shown to be functionally functionally relevant or significant variant, so it's with decreased function. And here is, and as I said, in osteosarcoma, and this is a known association that there could be germline TP53 mutation associated with this particular tumor type. And especially if you see two events, like in this case, clearly shown in clinical that there is deletion in sequence variant involving TP53, you would know to recommend germline testing. And in this particular case, targeted Sanger sequencing confirmed the presence of a germline mutation in TP53. However, there are many, this is just, again, showing that this is a well-known association between osteosarcoma and both somatic as well as germline TP53 mutations. However, there are many cases where this connection between a tumor type and detected variant is not so well recognized, well described. And in those cases, it's often those two events affecting the same gene that make us really focus on that particular gene, and also focus on possibility that one of the mutations could be germline. And to illustrate that, I wanted to quickly show a case of neuroblastoma. And so in this case, starting with copy number analysis, we saw some of the typical copy number changes that you see in neuroblastoma, and the gain of loss of 1p and gain of 17q. And these are recurrent abnormalities, copy number abnormalities that are associated with poor prognosis with aggressive disease. And there were also some non-specific copy number aberrations. But when we were reviewing this two events that are all focused in the same region on chromosome 19, in 19p. And so this is something that so having two events definitely brings your attention to this area. And when you zoom in, you see that both these events are actually affecting the same gene. This was SMARCA4. And the first event was partial gene deletion that affected 5' region of the gene. And then the second was sequence variant, which was a frame shift. So it was truncating pathogenic variant. And since two different parts of the gene were affected by deletion and sequence variant, there is nothing in variant allele frequency that would tell you that there is a second event in the same gene. So again, something that is the correlation that was much easier to make when you review copy number and sequence data together. And so because we had two events in SMARCA4, we really focused on this gene, although SMARCA4 is not well known to be associated with neuroblastoma. But we were able to find this recent study that looked at SMARCA4 mutations in neuroblastoma, and they observed mutations with relatively low frequency. It's only 2.5% of the cases, but in many of these patients, there were two hits in SMARCA4, suggesting that there is selection for the second event, and suggesting that these are functionally important events for this tumor. And then furthermore, there was a previous case reported with a germline SMARCA4 mutation, and where patient also developed neuroblastoma. And so by focusing on this gene that had two events, but was not previously associated with this tumor type, we were able to not just interpret more accurately what is the significance of these mutations in neuroblastoma, and we were able to show that, to find that manuscript that described SMARCA4 mutations in neuroblastoma. But we also recommended germline mutation testing because there is a possibility that a sequence variant may have been germline. So we thought it would be important to make sure that this patient does not have a germline mutation. Another quick example on how sometimes there is no obvious correlation between the mutated gene and the tumor type is this case that was actually published as a case report by my colleague Jenny G. So in this particular patient, he was diagnosed with embryonal rhabdomyosarcoma, but he had some other abnormal phenotypes, developmental delay, heart defect, dysmorphic features, cafe au lait spots, but his genetic diagnosis was not established at the time. By somatic testing, we detected a CBL variant, a known pathogenic variant in CBL that is associated with the Noonan syndrome-like disorder. So germline CBL variants are associated with Noonan syndrome-like disorder with susceptibility to juvenile myelomonocytic leukemia. So although this was found by somatic analysis, it actually fits the patient's phenotype. So it was felt that this is probably a germline variant that was associated with patient's phenotype. And so germline testing was pursued, and it was shown that this was a de novo variant in the patient, absent in both parents. And so it very nicely explains the patient's phenotype. And however, the only unanswered question or piece of the puzzle is the presentation of embryonal rhabdomyosarcoma, because that's not a tumor that you have associated with germline CBL mutations. These patients have risk of JMML, but do not really have described and published increased risk of solid tumors, and specifically embryonal rhabdomyosarcoma. However, if you look at CMA results and for these embryonal rhabdomyosarcoma sample, you see that there is a second event involving CBL region. So there is copy neutral LOH for chromosome 11, where this gene maps. And there's also a whole chromosome gain for chromosome 11. So even the third event that again overlaps chromosome 11, where we have the CBL mutation. And this is showing sequencing results from OncoKids, showing that CBL mutation present in 100% of the reads, And so we are seeing that there is a loss of the wild-type allele and duplication of the mutant allele, and then additional gain of a third copy of chromosome 11. So there seems to be some selection for a mutant allele in this tumor sample. And so again, showing all these multiple events in NX clinical, sequence mutation, copy control LOH, and also gain of a third copy of chromosome 11. And when we zoom in, we see sequence variant overlapping copy control LOH region. But then the presence of these additional events suggests that this is actually most likely functionally important variant in the tumor. And so this allows my colleague to propose that there is probably association between germline CBL pathogenic variants and solid tumors, specifically rhabdomyosarcoma. And this would further broaden the spectrum of CBL cancer predisposition and maybe warrant watching these patients for solid tumors, not just JMML. And there were some additional papers subsequently after this paper was published that also suggest that there is a risk of solid tumors. So finally, as the last case to illustrate the utility of integrated variant review, I wanted to show a sample of a Wilms tumor patient, example of a Wilms tumor patient. So this was a girl who was diagnosed with bilateral Wilms tumor, which is a little unusual. And array testing detected 11p copy neutral LOH. And so interpretation of 11p copy neutral LOH in Wilms tumor is complicated because there are two regions in 11p associated with Wilms tumor. More distally, there is imprinted region associated with Beckwith-Wiedemann syndrome, and Beckwith-Wiedemann syndrome patients have increased risk of Wilms tumor. And then there's also more proximal region where you have WT1 gene, and WT1 mutations can also have association with Wilms tumor. So when you see copy neutral LOH in Wilms tumor patients, that can be a completely somatic change, just sporadic. However, it still has importance in prognosis because even when you have a favorable histology, 11p copy neutral LOH is a marker of adverse prognosis. And the second possibility is that this is a germline uniparental disomy, germline segmental uniparental disomy, paternal, is associated with Beckwith-Wiedemann syndrome. Sometimes the patient's phenotype may not be obvious. Some of these patients do not have established diagnosis. However, they do have increased risk of Wilms tumor, and so you always have to make sure to exclude possibility of germline, mosaic, segmental UPD. And then finally, copy neutral LOH in 11p in Wilms tumor could be associated with WT1 mutation, which again can be either somatic or germline. So which of these scenarios we have in our patient? So if you look at the case in NX clinical, very quickly you see that there are multiple events, sequence events, and allelic imbalance, copy neutral LOH in 11p. And when you zoom in, you very easily see that the mutation actually is within WT1 gene, and it's a stop codon. Again, copy neutral LOH now most likely second event associated with this WT1 mutation. And you're quickly now thinking in the direction of WT1 mutation in this patient, and copy neutral LOH being associated with WT1, and you do not have to worry about those other possible scenarios. However, the next step is to determine whether this is a sporadic, somatic WT1 mutation, or this is possibly germline WT1. In Wilms tumor cases, both are possible. So in about 10% of sporadic Wilms tumor cases, there are WT1 mutations. However, if you have a germline WT1 mutation, that's associated with Dennis-Drash syndrome. And among other phenotypes, Dennis-Drash syndrome is associated with high risk of Wilms tumor. So the next step for this patient was to do germline testing, and that detected in peripheral blood sample the same pathogenic WT1 variant, which was detected by OncoKIDS testing of the Wilms tumor sample. So now you establish a diagnosis of germline WT1 mutation, or in other words, Dennis-Drash syndrome, and the patient, in addition to having bilateral Wilms tumor, was also showing signs of renal early onset renal failure, so she actually did have a phenotype that is consistent with the syndrome. So to summarize the tumor part of the talk, I showed us multiple cases that illustrate how by reviewing copy number variants, loss of heterozygosity, sequence variants simultaneously, you much quicker come up with the right interpretation of the significance of each of these variants, and you are less likely to miss a proper appropriate interpretation. However, our current workflow is still to do a CMA analysis as a separate test and report CMA findings, and then we do OncoKits analysis separately and generate OncoKits report. And then towards the end, the data, the key findings from both assays are combined with pathology findings, and that results in generating integrated reports. But at that time, when you do not have data from these assays in front of your eyes, and when you're trying to make some connections and correlations between the findings just based on these complicated reports, it is very easy to miss proper correlations and interpretations of some of these results. So what we think is that if we implement this clinical workflow where we are looking at CMA results and cancer panel results simultaneously, and we will be able to simultaneously review and report sequence variants and copy number variants. And that will not only help us to do our review and interpretation faster, but will also help us to more accurately correlate findings and interpret findings between these two assays. So in conclusion, what I showed in the first part of the talk with constitutional cases is how NX Clinical supports integrated detection and review of sequence variants, copy number variants, and regions of homozygosity from NGS data, because that was all exome sequencing data. And then in the second part of the talk, focusing on cancer cases, I showed how NX Clinical supports integrated review of sequencing results obtained through our tumor panel, as well as CMA results that we do separately for copy number testing. So the first workflow is something that we are looking to implement for our constitutional testing, and then the second workflow for our cancer cases. But either way, we believe that this will result with not only in increased efficiency, but also better and more accurate interpretation of the findings. So with that, I wanted to thank my wonderful colleagues at CPM, especially Dr. Jenny G, Dr. Schmidt, and Dr. Hemans, who very generously shared with me some of their slides and some of their most interesting cases. I want to thank our division chief, Dr. Beagle, and again, would like to thank BioDiscovery for the opportunity to talk today. But most importantly, I want to thank everybody in the audience who took time to join us today. And I will be happy to answer the questions if we have them.
Thank you, Dr. Rocca. We'll move over to the attendee questions now. Dr. Rocca, here's one. Can DNA microarray differentiate somatic versus germline origin of genetic mutation?
Great question. It cannot. So if you are doing only isolated somatic sample testing, so if you only test tumor sample, you cannot distinguish clearly between the two, but you may have some indications, some hints, whether it's germline or somatic. Often somatic variants are showing in what we say is mosaic, so they're not present in all the cells in the sample because you have a mixture of normal and tumor cells. And typically in your tumor samples, so things that we see as mosaic, we are inclined to think of them as more likely somatic, and then things that are completely non-mosaic, we are worried that those might be germline. Although we always looked what was the tumor content, whether we had a high or low tumor content, and whether there were normal cells in the sample. So there's no perfect way to distinguish, but there are some ways to suspect a specific variant of being more likely germline or more likely somatic.
Great, thank you. What were your reasons for not moving forward with obtaining CNV from NGS for your cancer samples?
So for cancer samples, we are still somatic exome sequencing for tumor samples, as well as additional tests. However, we are not thinking about using that as a first line, because it is more challenging to do in tumors, where we often have FFPE samples, poor quality, and a large proportion of normal cells, so you have to do very deep sequencing to be able to capture somatic variants when you have large proportion of normal cells. So it's because somatic exome is much more challenging than constitutional exome, and we will not be using it as our first line for all the cases. We will have it as a possibility. And that's why for our routine first-line testing to get this genome-wide copy number assessment from tumors, we will stick to the array and have that as an option, and as well as a combination with our NGS panel. So the answer is because it's much harder to do genome-wide sequencing for cancer, but we do want to have genome-wide copy number assessment, so we're continuing to use array.
Great, thank you. There's a question here. I'm not sure if you're going to be able to answer this, but somebody wants to know if you can comment on reimbursement for these tests.
Yes, that's another excellent question and a problem that we all struggle with. But reimbursement is slowly catching up with what the practice is. So I think it's being recognized that somatic panels are now standard of care. So these are slowly starting to be reimbursed, and maybe not reimbursed sufficiently to recover the cost, but certainly they're now being reimbursed by Medicare and most of the private payers. And in terms of oncology and CMA, so array testing in oncology, that's much more challenging. But there is now initiative to recognize oncology array as a separate CPT code. We don't even have a separate code to be billing for oncology CMA. So there is now a petition to introduce a separate CPT code for billing as the first step, and then there will be a lot of additional initiative required to also recognize, to also get payers to reimburse for the test. However, there are more and more tumors where the value of CMA is being recognized. So it's starting to show up in practice guidelines as a test that should be used for certain tumor types or brain tumors. It's starting to show up in some practice guidelines, and that will certainly help with reimbursement. So I'm optimistic that reimbursement will catch up, but it is a huge issue right now, and prevents labs from using these assays the way that should be used for optimal patient testing.
Great, thank you so much.